My charge is to explain modern cariology, evidence into practice in 15 minutes, which is clearly impossible, but I shall do my best. The paradigm in modern cariology is changing, it's shifting. I want to make the clear statement, this has taken some time to shift. And usually I'm quite depressed in terms of, in medicine it takes 15 years to see a change, in dentistry sometimes it seems to take us even longer. But there are some encouraging signs which I want to share with you to go up to date. So I want to talk about modern cariology back to the future, the evolution since 2002 of what some of you know as the ICCMS criteria or the ICCMS Foundation, which has morphed into ICCMS, which I'll explain, which is morphing again into 4D. The importance of caries activity assessment in this holistic caries management philosophy, and then very briefly, dental policy labs which have taken place. We've just had the second one of those earlier this week, and evidence into practice, Caries Care International. This is a new initiative from the ICCMS Foundation charity which seeks to put modern cariology evidence into practice. So when we start in a research setting to talk about the detection clinically of enamel and dentine caries, it seems a strange paradox that in many countries with many groups we say, oh, this is exciting and new. And the purpose of this slide is just so that you can choose your decade. So it was new in 1951 with Otto Bacher-Dirks, it was new in 1966 with Tommy Marthaler, new in Australasia and in the WHO in the 70s, and then in Hong Kong, in Canada, in London, in Scotland again, in Denmark, and many, many more. So when we talk about detection of enamel and dentine caries, it very much is back to the future. And ICCMS has been doing this since 2002. So the paradigm changes about once every 10 years, but each paradigm looks quite similar to the previous one. A number of colleagues from around the world contributed to a paper that was published last year which tried to be a primer, this is Nature Primers, to tell people who wanted to know about the science of dental caries everything you wanted to know in one paper. And it's a useful way of bringing together the information about the epidemiology, about the risk factors, prevention, the microbiome, saliva, fluoride, remineralization, the challenge of diagnosis, and how dentists still use sharp probes when they shouldn't, and then management in a rational way supporting the evidence. So in a way, this is a useful way of summarizing what we know about modern cariology evidence. And implicit in that is this balance between high risk, moderate risk, and low risk. It's been drawn many ways by many people. It's been popularized very much with John Featherstone and others. But we've got a whole range of pathological factors on one side driving demineralization, initiation and progression of disease, if the balance goes that way. And then we've got protective factors around diet, fluoride, professionally applied or home applied, and then therapeutic sealants, salivary function, and those can, if we push down that side of the balance, we get remineralization. So knowing at a patient level, at a surface level, this balance of demin and remin is fundamentally important. We now know a lot about the ecological plaque hypothesis. This is really from Phil Marsh from many moons ago, but it's very much the way in which we think about what's happening in the oral biofilm and the microbiome, that the increased sugar intake changes the natural environment of the ecology, selects for lower pH, selects for different groups of commensals. These are not infective specific strains, these are a family of bacteria that can produce acid and can turn a healthy situation into a disease situation. It's also important that we focus a lot on clinical visual detection and assessment of caries, but we need radiographic assessment as well. And that's a challenge because every time we expose a patient to ionizing radiation and make them glow in the dark, there's a health disbenefit. And we must know that there is a balance for that patient of getting diagnostic information which is more valuable than that risk. And the paper also sets out some of the background for what's known as the 4D method or 4D approach to determining patient risk at a patient level, detecting and assessing lesions at a surface level, including the activity, assessing whether a lesion is active and progressing, deciding on an individual patient level what does the personalized care plan look like, and then doing appropriate preventive tooth-preserving interventions, and we'll come back to that. Then there's a risk-based recall. So this is a management system. It's not just a caries detection system. It's not just a risk assessment system. It's an integrated approach to modern caries management. And in this paper, we see the decision tree drawn, and it's basically a railway map or a tube map here in London. How do I take the right information to do the right thing at the right time? And if we look carefully, you'll see that a key determinant of what we subsequently do for extensive, moderate, or initial lesions which are active is different to what we do for all stages of lesions which are inactive. So the activity of a lesion, whether it's losing mineral right now at that particular time, drives some of the treatment decisions and care planning. And at the bottom of this, it's worth just stressing that we've got 3 types of treatment apart from risk management. We've got tooth-preserving operative care of some lesions. That's what we do only when we have to. Non-operative care of lesions, control of initial lesions, and keeping sound surfaces sound. So that's the do. The evolution of this process started in 2002 when IADR, FDI, the FDA, a whole range of people and many international companies came together to look at how best to do caries clinical trials. Some of the protocols hadn't changed since 1968, and that was a slight concern. What came out of that consensus meeting was a very useful clarification of the difference between detecting lesions, have I got disease or not, assessing lesions, characterizing their behavior, monitoring them or assessing the activity, and then the diagnosis, which is what the human being, the dentist, the clinician does, not the robot, not the computer. And that drove the ICCMS, formation of the ICCMS movement, which is International Caries Detection and Assessment. So that meeting was in 2002, and it was really embarrassing because dentistry and dental research had to say, we can't compare the results of all our studies because we've used a different measuring stick for caries. So different countries, different companies all use different criteria. So a group of us got together, the meeting was in January, the first meeting of ICCMS was in March, to try and harmonize what we did for detection and assessment for epidemiology, for practice, for research, and for education. And that's been the thrust of what we've been doing since 2002. What we're trying not to do is work, again, cutting edge work, back to the future from Elderton. The original work in Scotland reported in 1990 and at the end of the 90s. But this is the so-called spiral where we restore a tooth, we put in a filling, we put in a larger filling, we involve more surfaces, we then involve the pulp, we involve endodontics, repeat crowns, and of course this is so old we don't have repeat implants, but we can add to that, and it's been duplicated in many other countries. So trying to control the caries process prior to filling is really very important. And in the ICCMS wardrobe, this is a slide from 2007. This is our practitioner, note how smartly they're dressed. Professor David Ricketts decided that underpants was the appropriate way of looking at clinical visual assessment. You always had to wear them, and they were the foundation of treatment planning. At that time, we wanted a lesion detection tool, that's your bite wing radiograph, but we also said that what we really wanted was an activity assessment tool. And at that time, we didn't have one. Now we do. So as it's matured, we've got these 4 different domains of ICCMS. Basically, again, this is practice, this is public health, this is education, this is research. And the core ICCMS version is simplified into 3 flavors and sound: initial, moderate, and extensive. And that's helped people from general practice and elsewhere understand better what we're doing by staging severity. The system has been publicized, developed, peer-reviewed, and we've had a couple of meetings in different places which I'll refer to. So ICDAS became ICCMS, clinical and radiographic, and the idea is caries management pathways to preserve dental tissues. So it's tooth-preserving operative care and trying to promote health in the long term over the life course. So this then moved to a consensus document where we had 75 authors trying very hard to agree, and the charge was not to write a textbook, so we ended up with 42 pages and 40 pages of appendices, which looked a lot like a textbook to me. But it's been useful that in the US and elsewhere, this is from GIADA, the American Dental Association classification system, which is based on ICDAS and represents similar codes. So we're getting harmonization of how we detect and assess, and then we've been trying hard to simplify, and we were asked to put all of this on one side of paper, and there's the start of the 4D. So the website for ICDAS is now called ICCMS because we're looking at the management system, and in the house there are 4 windows for those 4 different domains, and we've got the 4D. So in that context, caries activity assessment is really important, and this slides back from that 2002 meeting of the caries clinical trial consensus meeting. A lot of effort to detect lesions and stage lesions. We're looking at monitoring over time and seeing whether lesions are progressing. But this was identified as the important area for both clinicians and researchers, assessing the activity of the lesion. Is this lesion active today? And the ICDAS group produced caries activity codes. But the activity assessment has always been more of a challenge than the staging. There's monographs and references and summaries that take us through the research that's been done around the world in lesion activity assessment, and we have some speakers today who can help us with that. What we're now looking at is a technology where we've got an imaging system that can identify on pits and fissures the areas which are actively losing mineral. And why that's important is that we can have an initial lesion, initial occlusal surface, which we're not sure about, imaged. We can then spray on an active photoprotein, which you'll hear more about, and then those images can be overlaid, and the clinician will know better now, is that likely to be an active lesion that we should worry about, or is that a lesion that's been there for 5, 10, or 15 years that we don't need to worry about? Most importantly, I think we also now have a way of having a dialogue with our patients. So the discussion and being able to show surface by surface has a real benefit. So just to finish off, as I said, the paradigm is shifting, but we are now making progress. We've had 2 dental policy labs where the Policy Institute at King's College London has been working with the Dental Institute and a group of health economists, bringing together a range of different stakeholders, asking the question, how do we accelerate a policy shift towards increased resource allocation for caries prevention and control? You might wonder what that's got to do with contemporary caries management. A lot of time people have said, well, the reason that we don't in particular countries do much preventive dentistry in routine practice is because we don't get paid for it. So this group was assessing what needs to be done to put more resources into paying for prevention. And there's 4 main outcomes: demonstrating the value of a cavity-free world or preventing caries, caries prevention-based payment systems where there's fragmented work, better equipping the dental and healthcare workforce, and shifting public and industry behaviors. And the cube that you see represented there is, I think, a very helpful step forward in that we've identified the different stakeholders that have to align in some way if we're going to make progress. If anybody's interested, on the website, and I can give you the links, there is a full report of that first policy lab meeting. What we've had earlier this week is a second lab towards paying for health in dentistry, and that's been looking specifically at how do we create and implement acceptable prevention-based payment systems. And here you see a very interesting group. 50% of them were in the first lab, 50% in the second, 50% were new in the second. And we've got chief dental officers, we've got FDI members, we've got health economists from around the world, we've got dental associations, and over a 24-hour period, they have come up with, and this is very much a draft, but they've come up with a way of specifying how we pay for prevention and how we pay for comprehensive caries management. And that fits into what the US insurance industry are telling us, what the UK is experimenting with, what Singapore wants to do, and what other countries want to do. So that's helpful. And a final part, just in terms of keeping very much up to date, we track across the top there at the ICCMS developments, 2010 Montpellier, 2012 Temple, Philadelphia, 2013 King's College London, the various documents, and then there's been research and evaluation showing that patients like this and dentists like this. We've also got the issue around minimata and the legal requirement to phase down amalgam. And what's been created is a practice-friendly version of the 4Ds. So the purpose and the goals is to prevent new lesions from appearing, to prevent existing lesions from advancing, and to preserve tooth structure. So we're trying now, as a new part of the ICCMS Foundation charity, to create a new entity called Caries Care International, which was launched in Copenhagen July 3rd, which has a mission to have a simple, viable, practice-friendly way of driving this 4D model. And in detect and assess, we need to assess activity. So you'll see that the subsequent presentations fit very much into this model. France, by the way, has decided to do a national experiment implementing the model that I just talked about through the French Health Service as part of Macron's reforms. You'll hear more about Caries Care International through websites, consensus development, documents, social media, and other communications. So in summary, I've tried to tell you a little bit about caries management. Some of it's back to the future, some of it's new and shiny and exciting. We've had evolution from the different acronyms, ICCMS to ICCMS to 4D. Caries activity assessment is an important part of all this. And I think that the involvement of other stakeholders around the financing systems and how you pay for prevention is also very helpful in removing one of the barriers. And we now have a new part of the ICCMS Foundation charity dedicated to making this work in routine practice around the world. Thank you very much for your attention.